We're looking at the national strategies to promote equitable access to surgical care, and more so in the communities of high need, or what I would call communities which have less access, communities which may be vulnerable to sudden changes in infrastructure, who may be vulnerable to natural occurrences. And so we'll discuss this more in depth as we go along. But first, I wanted to talk about what is global health. And since this is an interactive session, I would like the members on the team, someone can volunteer and tell me what is global health. What do you think global health means, Rosalind? Let me start with the moderator. Hello,
Okay,
am I
to
heard?
me, global, yeah, you heard,
Yes.
doctor. So to me, global health is deals with addressing health issues right from the grassroots, addressing them from a community point of view. Yeah, that's I could give a brief. Yeah.
Thank you so much, Rosalind. That is true. And actually, what I like that you've mentioned there is grassroots and community, because global refers to the world over, pertaining to health factors that are common the world over or connected the world over. And we can see that communities are usually connected. They may be connected by grassroots, they may be connected by branches. And so I like that synonym that you've given, describing global health. And so we now understand as healthcare workers that no one is isolated, no one is an island. I'm not sure how many of you like watching movies, but I used to like watching movies. Now I like more documentaries. But there's one movie that stood out to me called The Butterfly Effect, where, you know, one small action that the protagonist would do would affect his family, his neighbors, his friends, not only at that time in his life, but in their future, the foreseeable future and the distant future. So we need to understand that we are all connected. And even though we are here in Uganda, East Africa, we are connected to people in Kenya, we are connected to people in Tanzania, etc. And even in the region of Eastern Africa, the continent of Africa, and globally. I also wanted to point out about surgery, because global surgery is a new concept, relatively new concept. There was a lot of public health 15 to 20 years ago, and a lot of emphasis on communicable diseases. We used to call them ATM. So AIDS meaning AIDS and HIV. T is for the TB, and M is malaria. ATM diseases used to get a lot of airtime, a lot of funding, and appropriately still do, because they still affect our communities, causing a lot of disability, death, and disorganization in the community. Because not only the patient who is affected, but if the patient is a breadwinner, or if the patient is, say, a vulnerable member of the family, like a young child under 5 and they fall ill, or their life is lost, the family will not remain the same. Now bringing surgery into the limelight, surgery never really used to feature in global health, but I'm glad that it's coming to the forefront, because it is sometimes a neglected illness. Like we mentioned, a lot of attention may go to the communicable illnesses, and now non-communicable like hypertension, diabetes, obesity, getting a lot of attention and appropriate resources. But surgery may be neglected. Now, surgery in itself, you need to look at it as multifaceted. It has multiple areas where it may touch on, for example, trauma. And we get a lot of accidents on the road, motor vehicle accident, border accident, etc. Then tumors that may need to be removed surgically. And then things like GI conditions, such as peptic ulcer disease, and then endocrine illnesses, commonly what stands out to me is things like neglected thyroids that are enlarged. This is just a picture which I obtained from one of the partners of Ministry of Health called Bulamu. So we are noting here that there's a lady with a large goiter. We are not sure of the details of her story, but we understand that every patient has a story. They may have challenges accessing healthcare, and hence conditions which start out initially seemingly small may then develop in more serious conditions with complications, because such a large goiter can then cause other complications like airway obstruction. It can cause compression of the vascular features in the neck. It can cause obstruction not only to swallowing, okay, but also speech. It can affect the speech and the voice quality. Imagine if that lady is a breadwinner in her home and she's a teacher. She may have a challenge being able to continue her career as a teacher because you need a lot of speaking as part of your skills, okay? But also there is the unseen. Sometimes patients feel vulnerable when they have large masses or conditions that they have lived with for a long time, and these are often surgically amenable. They can be corrected by surgery. So the areas of concentration in the nation of Uganda, where we are trying to improve access to quality and safe surgical care, include these that are listed here: 7, human resource, infrastructure, equipment, systems, safety and quality, and financing. The last one of camps, you can look at it as a transient or a catch-up way of dealing with the backlog of surgical cases, especially in areas that are vulnerable or hard to reach. Now, this makes me circle back to what are those areas that we consider vulnerable or hard to reach. So there are many different areas that could be under this category. You may look at areas that are economically disadvantaged, say those who live in perhaps urbanized areas which are not well planned or well executed, and they may also lack representation in certain socio-economic classes. So for example, if you look at areas like Makere, in Katanga, you look at areas, certain areas of Bwaise, those may fall, even though they're in the urban areas, they are disadvantaged socio-economically. Okay, so there's a socio-economic. Then there is the geographic. Now, often health centers are in certain areas and referral hospitals are in certain areas, but these may be hard to reach. For example, if someone is a patient in Moroto, I know many of you are in social media and you follow Dr. Gladys, the ophthalmologist, because she's availing a super specialized care to a select population in an area that is hard to reach. I don't know how many of you have ever gone to Moroto? Anyone by show of hands? I'm here, but I'm not seeing any hands. Yet people would think that maybe if you have gone to a medical school up country, you are more adventurous. You may have access to certain trips into the community. So they'll think maybe people from Gulu University have ever been to other upcountry places, but it may not be so. Apart from that, we also look at areas that are sort of cut off or isolated by terrain. For example, there are certain communities in Buindi that are cut off by terrain, okay? And then that makes them vulnerable to lacking adequate access to safe and quality surgery. Some are cut off by water bodies. So some islands like Buvuma, I don't know how many of you have ever been to an island. I've been to, I think, 3 islands in Uganda. I used to like going on boat cruises a lot when I was when I was younger, but now I'm a bit more risk averse. Okay. So that's what we mean by geographically vulnerable. So we talked about socioeconomically vulnerable, geographically vulnerable. Okay. And then we also need to think about those who have cultures which may be a bottleneck to access to care. What do I mean? Sometimes there are cultures where they are really self-sufficient, autonomous, and independent. For example, if you look at the cattle keepers in Karamoja, they really believe their culture is self-sufficient and autonomous. They not believe so much in healthcare. I'll give another example of the nomads in Namibian deserts. They are also culturally unique, and they may be isolated from safe quality surgical care. So there's socioeconomic, there is geographic, and then there is cultural, okay? The geographic, we shall talk more about it. Let's keep moving so that time is not lost. Now, when we talk about human resource, what do we mean? Human resource, although I listed here specialist training, the surgical team is made up of so many people. In order for you to have a successful surgery, there are so many blocks in place that need to be right and built one on top of each other. It must move like a well-oiled machine, okay? I don't know how many of you here like cars, like not only looking at them, but tinkering with them, repairing them, putting them apart, putting them together. In order for your car to work, there are so many things that should be working well and working in unison. So that's what we mean by a well-oiled machine. What do I mean? In a surgical team, before you even get to the theater, you need to have at least a team on ground that ensures that the place is clean, the hospital is clean, and the theater is clean. So you have janitorial and support staff. Very important. If you've ever gone to a hospital and it's dirty, you understand what I'm talking about. 2, there are areas like biomedical specialists, because there is no way you're going to operate well when the theater table is not working well, maybe, or if you have a challenge in one of the equipment, like diathermy for cauterizing and stopping bleeding, you need to be having appropriate support from such teams. Nursing team, extremely important in caring for the patient, preoperative counseling, preoperative preparation, such as making sure the patient is ready for theater, removing jewelry, making sure that they have a next of kin who take care of them, etc. And then also medication that they are receiving, okay, and counseling. So these are really important teams. So now when we move away from those that I've mentioned, now we do go to the specialized medical teams. Surgeons don't work alone. They work with, for example, anesthesiologists. I know there are a lot of memes that circulate on social media which show that we maybe some head butting between surgeons and anesthesiologists, but actually they are our best friends, okay? We cannot live without them. Yes, it is true. Unless you say you are going to revert to the old days of giving some form of brain-altering substance, but we need anesthesia so much, not only intra-op, but preoperatively to prepare our patients, okay? To optimize them very well for surgery and to advise us if there is any condition that needs to be sorted out. For example, if someone has a pheochromocytoma, you haven't controlled the BP, systolic is 200. The patient is having palpitations, they're having cardiovascular strain, and you think you're going to take that patient to theater and remove that pheochromocytoma safely and have them out of OR walking? No, you need to prepare that patient very well. That also brings in other specialists like physicians, pathologists, etc. Okay. Now, task sharing. When we look at things like task sharing, that means we're looking at certain cadres to assist us with surgical illnesses. For example, medical officers may assist with once they are properly trained and supervised, and you know that they're now able to do it on their own, they can assist with things like cesarean sections, excision of small masses. I remember when I was in Lacho, we used to do a lot of work. For example, circumcisions, appendectomies, hernia repairs. That was because we had gone grueling, efficient training by the senior surgeons in Lacho Hospital. And they were still there in the hospital available to supervise us, okay? When you look at task shifting is more like, say I'm a neurosurgeon and I'm going to train general surgeons on how to manage common conditions that may come to them in their regional referral hospital, say if there's no neurosurgeon there, or other hospitals. For example, management of commonly occurring subdural hematomas, chronic subdurals, or epidural hematomas, okay? There's also national partnership with training institutions to make sure that they train and put out many who will assist in surgery delivery, such as College of Surgeons of East, Southern, and Central Africa, okay? The Royal College of Surgeons of England, the Royal College of Surgeons of Ireland, and they don't only train in surgery, but also additional degrees like PhDs, management, administration, etc. Then mentorship and outreach. I don't think I have to say so much. This is already part of mentorship and outreach. So you see here, this is just highlighting certain areas in human resource which may be challenges, such as one, high turnover rates. Maybe someone is a medical officer, they are employed somewhere for maybe 1 year, but they know they want to go back to school. They go back to school after 1.5 years. Then you're not sure if they'll come back as a specialist surgeon. The number 2 is hiring difficulties. Sometimes there are so many ladders and steps you are presented with and have to get over before you are hired. You may have graduated, you have your degree, you have all the pips, but then now they are going to say maybe you need a PhD, or you need an additional administrative, or maybe public service has their particular calendar, understandably, that they follow for hiring human resource. So also regulatory compliance. This one is a bit fluid because we are under UMDPC, and once you are cleared by UMDPC, you have appropriately supplied the paperwork, then you should be okay to work. Mental and physical burnout. This is very high in the surgical field. I can give you an example. When I was a resident, I used to, in casualty, sometimes we would work for many hours. This cuts across the world, by the way. This is not only in Uganda, but even neurosurgery the world over. You work long hours. It is physically demanding, emotionally challenging, and it can take a toll on your psyche, okay? You stand for maybe 10 hours. One surgery, if it's complex, maybe 10 hours. If they are short surgeries, say like subdural, or someone has a fracture that you're going to elevate, say maybe like 1.5 hours, 1 hour. But that takes a strain on you. And we may, if it's not dealt with appropriately, it may reduce your productivity. Workforce challenges like shortages. I think we see this clearly in certain areas that I've already mentioned. Number 9, employee health and safety. So for example, if you're exposed to certain occupational hazards, so for us surgeons, a lot of ergonomics, posture, that standing in theater and twisting your neck and looking through the microscope may have a long-term impact on your neck and your spine, okay? And that may impact your output later. Budget constraints, we are going to talk about later. Technology integration. This is something that I see nationally we are embracing, and I'm so glad. I think it's because majority of the population in Uganda are youths. I believe it's over 65% from the last census. Someone can correct me. Yeah, but it is so, and the youths are very fluid, flexible, and free, and they take on technology quickly. And good enough, we have many youths in the medical field. So we are being championed to integrate technology in our day-to-day practices. Then diversity and equity and belonging. So here you can see, we look at things like including female neurosurgeons or female residents in training, The ratio in surgery is still about 1 in 4. So for every 4 male surgeons, you have about 1 female surgeon, okay? And even so in neurosurgery, it's about 4 or 5. So every 5 male neurosurgeons may have 1 female neurosurgeon, but we want to include them because they bring a very unique perspective to that practice. Now, infrastructure, we're talking about, first, we'll talk about the actual hospitals and buildings. And we see that in Uganda, the aim per our National Surgical Obstetric and Anesthesia Plan, NSOP, is to have at least 1 functional operating room per 100,000 people. So what we have done nationally is look at 1, building new health centers. So you will see that certain health centers may have been built, say like Mbuya, military, okay? Then 2, we are looking at expanding the currently existent ones or empowering them to take on larger populations and more complex cases, okay? So you see that many of the regional referrals now have been supplied with a functional CT scan. Once you have a CT scan, then other things are also going to be able to occur there. You're going to be able to do assessment for tumors, complex tumors. You're going to be able to do assessment for brain conditions like subdural hematomas, epidural hematomas, and you can plan operatively on your approach, okay? We're also looking at functionalizing certain mobile theaters. Has anyone of you ever seen a mobile theater? Anyone? I saw my first one this year. So there are mobile theaters around. Walter Reed, and this comes under public and private partnerships, has had, I believe, 2 mobile theaters that were working in Eastern Uganda. Okay. Then there is a mobile theater with the Kabaka Foundation. And in those theaters, you may be able to do certain operations such as circumcision, so safe male circumcision. So instead of struggling with people walking to a health center 80 kilometers away, you take the theater to them. You have the health personnel, you equip the theater, bring the sundries, operationalize it, and you drive to them. It's a similar concept to what we see with the Uganda Cancer Institute mammography van. Has anyone ever seen that mammogram van? But no one is responding to me. Now I'm going to start picking for randomly. Charity, at Geelong, have you ever heard of the UMI mammogram van? Ewutia is laughing, but he may be next to be picked randomly. I was just checking if you are awake. Okay. So then repurposing infrastructure. You'll find that sometimes you may find a school that, say, closed or moved to another building, and it is now used for healthcare. Yes, thank you so much, Kennedy. Kennedy has ever seen TB, mobile TB. So now you imagine something like that with a mobile theater. So it's not only happening with non-communicable diseases like cancer, screening for cervical cancer, prostate cancer. It's not only happening with communicable diseases like TB, AIDS, HIV screening, but also surgery, which is awesome, okay? Now, apart from the housing, the building, infrastructure also entails these 3 things: electricity or source of energy, 2, water supply, 3, access. So access has both road access and terrain. Now, electricity is a necessity for any functional surgical center to be efficient. You have to have 24/7 electricity. If you don't have that, you need a backup power supply, such as solar or windmill or water. You need some other backup source. Many times in Uganda, what we have utilized and harnessed is the solar systems because we have a lot of sunshine, as I'm sure you've all been experiencing and enjoying. I don't know how is Gulu these days. Let me ask someone randomly here. Dalton, how has the temperature been in Gulu? Are you in Gulu or you're somewhere else? Are you everybody Dalton? Hello. Maybe I asked Ewuchia because he was laughing. How is the temperature? I remember when I was in Lacho, it used to shine seriously. Okay. So we would use that solar to make sure. So you've seen many of those health centers. For example, if one of you has been to Eastern Uganda, Shavira Surgical Center, they do a lot of endoscopies, okay? And they have solar panels on their roofs, okay? And they have that backup option. Now, when we go to government health centers, there's what's called the yellow box. Has anyone seen the yellow box? Marvin, I don't know. Marvin, are you there? Or Ketayot? Dr. Senoni, everyone is on mute. It's like they disabled their audio when they were joining.
Yes, I'm here. I had trouble unmuting.
It's okay. Have you ever seen the solar yellow box in theaters in government hospitals?
Yeah, I think I've ever seen them, if I'm not mistaken. Yeah, I've ever seen.
Okay, which health center did you see it in? All right. So I recently visited Buvuma Islands, and that yellow box acts as a backup lighting supply. In case you're in there and you have a sudden loss of power in the middle of the C-section or in the middle of an abdominal laparotomy, you have at least backup power. Okay. Water supply is also extremely important because there are many things that are going to run on water. You need to clean the hospital, you need to clean the theater. Once you've done a C-section, it's really bloody. Once you've done sometimes some abdominal surgeries where, say, you have an appendicular abscess, it can be really foul and bloody. And then when you're irrigating, you irrigate with a lot of fluid and it can overflow to the floor. So you need to be able to clean the theater, okay? So you need like piped water supply, like National Water and Sewage Corporation, but also you need a backup supply. Say, for example, rain harvesting, okay? Or harvesting from wells, underground tables, all right? Now, when we move to access, okay, Marvin, someone in a watch. Thank you. When you move to access, we talk about both road and terrain because sometimes you can have a road, but the terrain is not friendly. Let me give you an example. Who has ever been to southwestern Uganda, Bwindi? Anyone from there? I saw someone here. Do we have Mumbere?
Yes,
Felix,
doctor.
Mumbere, where is your village?
I come from Kasese, doctor.
How is, anyway, you are born there, so I think it may be okay for you. Have you ever taken a friend on a bus ride there?
Not
Visit
really,
your
doctor.
village? Not really, okay. I'm not isolating you, I'm just giving an example. I remember the first time I went to Bwindi, I keep bringing up Bwindi, and the road was up on the mountain and having a lot of snakes and corners, turns and corners. And to the side of the road, it's like a cliff drop, a very sheer, sudden, deep cliff drop, okay? So the driver had to be extremely experienced and careful driving in certain terrain. So you can have the road access, but you need extra experience in driving that terrain, okay? Has anyone heard of, let's say, the bellwether procedures? Muchivi.
No,
Muchivi, are you there?
I've not heard of one.
Okay. So bellwether is kind of like, if you look at a standard unit, it's like saying having a standard unit of a surgery that you should be able to do in every health center for. That you should be able to conduct a C-section in every health center for, meaning the facility must be there, the infrastructure must be there, access, road access, electricity, water, the health workers must be there, the additional auxiliary teams must be there. okay? And sometimes in hard to reach areas, geographically hard to reach areas, they may not have access to having all those teams in place to deal with at least a bellwether procedure. I implore you to read it up. I just put this picture here because it looks so neat and beautiful. Does anyone know which hospital this is? Dauda, do you know which hospital that is?
No, I'm not sure of it.
All right. It is the Mulago Women's Specialized and Neonatal Hospital. It looks so beautiful. And if you've been inside, it's very spacious, fresh, functional. Things are new, things are moving, working. But how many health center 3s or 4s, because health center 4 is where surgery is going to occur, we have a theater. How many may look this beautiful? I'm sure you've had community outreach, so you can answer that question. Now, next we look at equipment. Don't worry, I am almost winding up. Equipment, we are looking at not only hospital equipment, but also theater equipment. Now, the Ministry of Health has worked tirelessly to ensure that health center 4s and hospitals and regional referrals are equipped. I keep coming back to Ministry of Health because we are talking about national strategies, okay? So they've had a program where they roll out, I already mentioned about the CT scans, that was targeted. You need to have a targeted timelined program, meaning it is dealing with a particular objective and it has a timeline, and then you dedicate the necessary resources to it, like human resource, finances, etc. So recently I was somewhere up country, and we noted that the theater was well equipped. It had appropriate equipment for anesthesia. It had the theater bed that was functional and appropriate. It had the autoclave. Actually, I think they had 2 autoclaves, okay? They had the scrubs, the reusable gowns, and the linen for the patients. So those are strategies that have been put in place to ensure that when the patient gets to the hospital, it is not one pack of linen that has already been used on a prior patient with a ruptured appendix, but there are multiple packs, around 6 packs for C-sections. They'll have like 4 hernia packs, and they are able to execute safe surgery, okay? Then also basic instruments. There have been a recent drive by the government institutions, including Ministry of Health and collaborating institutions and MS, to ensure that they supply the basic surgical instruments to the health centers to allow people to work, okay? Oxygen. Oxygen, is any one of us here without oxygen? We don't think about it, you don't regulate it, you're not conscious about it, just breathing in and out. But oxygen is a very extreme necessity in surgical care, because when you are put under anesthesia by the anesthesia team, most likely you're going to need either supplementary oxygen. Even if you're sedated and you're not put under general anesthesia, you need some nasal prongs with oxygen, or a face mask with oxygen mixed maybe with some additional anesthetic agents. If you're under general anesthesia, you need to get an oxygen supplementation before you get general anesthesia. Have you been to theater and you see the anesthesiologist or the anesthetist putting the mask on the patient before they are given anesthesia, general anesthesia? Anyone? Chibula. Ewutia is very active. So thank you for that response. Yes, you need oxygen for safe surgery, okay? So many plants, for example, here in Mulago, they had initially, I think, 1 local plant. When COVID happened, the demand for oxygen went up. So they outsourced and brought 2 additional major oxygen generating plants, okay? And then continued the prior plant, which would give oxygen in cylinders. The 2 new plants were now supplying piped oxygen, which also goes to the surgical wards, it goes to the theaters, etc. Supply chain, ensuring that equipment which is procured for surgery, for healthcare, gets to where it is needed. Okay, I don't think I have to say so much more about that. And then maintenance of equipment. Ministry of Health has a dedicated team, okay, that reaches out and goes to do assessments at the health centers and upgrades and maintain equipment. Okay. Now we're going to talk about referral and transport systems, and I think partnerships, and that's it. Referral and transport systems. So many times the surgeries that are required may not be able to be executed at the health center. It may be because someone has been with their surgery with their condition for a while. A patient has a barrier to care. What are some of the barriers to care that we know of? I'm going to start picking people randomly. Someone is labeled NN. Who is NN? Hello, NN, are you there? Okay, maybe Zachary. Zachary, I like that name. Zachary, tell us, what bottlenecks do you think patients in Uganda meet when they have a surgical condition that may delay their access to safe care? Hello, Zachary, are you there? Oh dear. Okay, what about Moses Sekamembe?
Yeah, thank you so much, Doctor. Yeah, I think one of them is poverty. For example, even accessing the few health center pools and regional referral hospitals and many hospitals can be challenging to some people to go there.
True. Very true. Cost is a big bottleneck. Very big bottleneck. Actually, even amongst us medical personnel, okay, you may have a challenge with finances, and then because of that challenge, you may fear to go to the hospital. Okay, maybe your colleagues may assist you, but there are some additional things that need to be what? Bought. Okay. What other challenges? I think I already mentioned them prior. I talked about cultural bottlenecks. Okay. I talked about geographic bottlenecks. I talked about economic bottlenecks. Okay. Sometimes they are social. Sometimes a breadwinner is a single parent household, and that single parent knows that if they fall ill and they undergo surgery, they'll need to recover for at least 6 weeks, minimum 6 weeks, but up to 3 months. And then they think, who will win the bread when I am down? Who will pay the bills, pay the power bills, water bill? Who will buy food? So sometimes there are things that are social that are preventing people from seeking care. Sometimes it is stigma and shame. Some conditions are shamed, and so patients fear to go to hospital because they will say, now people are going to say such and such about my condition. Does anyone know such a condition which may have been stigmatized in the surgical world? Anybody? Okay. So before, thyroids, enlarged thyroids used to be so stigmatized. Even the vernacular name sounds a little bit unusual. Okay. So sometimes it's that. Okay. Social blockage. So how do we deal with this? Ensure that there are ambulances that are functional and well equipped, and the drivers, the personnel for running those ambulances are there. To ensure that there is communication, there should be a communication portal between health centers, not only in the government infrastructure, but also in private. When I used to work in IHK, we had a system. I worked in IHK for some good years in accident and emergency on the night shift. But we had a communication system between hospitals. You are referring a patient, you call ahead of time, let the healthcare worker speak to the healthcare worker in the receiving institution, give at least a summary about what the age, sex of the patient, diagnosis that they're working with, key issues for the patient, key treatment they have received, and reason for referral, so that the receiving hospital or institution can prepare itself. You cannot understand the challenge you get when someone refers to you a 28-week neonate on oxygen, premature, and they haven't told you that that patient is coming. Do you see the things that are their challenges? Patient is already preterm. They are small for weight. They are at risk of hypothermia, hypoglycemia. They possibly do not have adequate surfactant. So the lungs, the alveoli are all collapsed. They need high pressure oxygen, but not so much oxygen that you're going to cause damage to their retinas. Okay. On arrival, they need to have a cot ready for them, a warm, clean, dry cot ready for them, and at least a midwife as you wait for the pediatrician, not even mentioning the neonatologist. And then you need to think about the space they are going to be in the NICU, isn't it? With a warmer. And you haven't called. Come on, my people. Let's not be that person. Okay. Other strategies also in place include telemedicine. So sometimes you may have a patient in a hard-to-reach area, but you have healthcare workers at that site who can do telemedicine to assist in pre-op assessment of a patient and even post-op follow-up. Okay. So you can, these days we have a lot of modes. We can use phones, we can use video calls, you can use computers and do this care for the patient. Community awareness is also very important. Have you realized that some communities, if the LC1 chairman has not told them to do something, they will not do it? Have you realized that? So do not never underestimate the power of communities and referrals. This is the second last one, I believe, quality and safety. We look at quality and assurance committees that have been set up in different hospitals, both private and public hospitals. Okay. Those assess the situation on ground and see what can we do better. This is not fault finding, but fact finding. It's like an audit. What caused a challenge in the system? So always look at it as a system. Does anyone know what a root cause analysis is? Happier. Sylvan Happier. What about Elijah Sonko? The class is mute. Okay, I'll move on. We in surgery are so pressed about the surgical safety checklist. I know you've heard about the surgical safety checklist. It's supposed to be run for every patient who enters theater to ensure that they get safe surgery. You can still do this no matter where you are, even if you're in Karamoja, even if you're in Buvuma on the island, even if you're in Lake Choga, even if you're in Bwindi, please, you can do the surgical safety checklist to ensure that your patient is the right patient, they're getting the right surgery on the right site for the right reason, and you have the right post-op plan for them. Do we remember those elements? Right patient, right surgery, right site, right reason, and the right post-op plan for them. Okay? We also look at other things like tracking data, research to inform us about the quality of surgery in a health center. The last bullet there is credentialing. You want the right person doing your surgery. So has anyone ever seen this safety checklist?
Yes.
Yes.
Me, I've not seen it.
Oh, okay. Which year are you in now?
Year 5.
Wow, you've rotated in OBGY and surgery?
Not yet for senior clerkship.
Okay, so I would like you to look out for this list and read about it, okay? We move on to financing and removing cost barriers. We've already talked about cost being a barrier to healthcare. So in the public facilities, sometimes they'll say surgery is free, but perhaps we need to consider there may be some other costs that arise, maybe for certain restricted medications, etc. Okay? Ministry of Health is really pushing for fully funding surgical consumables. I know, for example, for us for neurosurgery, I know that we have champions. For example, Honorable Dr. Ayume Charles really pushes for neurosurgical consumables. I can give you an example. When we are doing surgery in casualty, there is a certain magic fabric called Surgisil that helps stop bleeding. So because the brain is very delicate, you may not be able to ligate it with sutures, tie off bleeders, no. And you may not be able to use monopolar diathermy, okay? So sometimes you need that, I call it a magic blanket. It's a small fabric, it looks like it's made out of polyester, it's white and shiny, and it actually contains material that is able to allow coagulation to occur. Okay, so we have been pushing for that, but one small packet is around 200,000, and each person who's going, say, for an epidural needs 2 of them or 3. So you're asking someone suddenly consider coming up with that cost of 600,000. So good enough, Ministry of Health has enabled to supply some of these consumables to us. Health insurance. I know we have been pushing for a national health insurance, but as we await that, there are other private not-for-profit entities that have brought about health insurance, and then there are the private ones. Has anyone seen some health insurance companies in Gulu? I know they are there, okay? So they are planning to roll out that policy for every Ugandan to be covered, and it's a beautiful thing. If you ever visit our neighbors in Kenya, I want you to keep an eye out for that. They have a well-run health insurance scheme. Community fundraising and corporate social responsibility. You've seen Centenary, Stanbic, etc., all those banks that do some healthcare or assist health workers in providing surgical health care. We really work a lot with them. I really want to highlight institutions like Gulamu, like Chavira Surgical Care Center. They are doing a great job. And this is the final slide because we talked about rescue plans or therapies such as surgical camps and outreaches. And these are to deal with if you have a massive backlog and you want to catch up, you can run camps. I think next week, Shudu is going to be running a camp, an endoscopy camp. Okay, Mulago ran a number of camps earlier this year. There was an ortho camp, there was an ophthalmology camp, there was in Jinja Regional Referral, there was a cardiothoracic camp for heart surgeries. There's going to be a neurosurgical camp in early August. So those camps help to mop up when you have a lot of backlog. Okay, and even our institution, Association of Surgeons of Uganda, ASAO, we have a camp coming up in mid-September. We were in West Nile last year, West Nile sub-region, and so we rotate in different regions of Uganda. Not only government institutions or other association institutions do camps, but NGOs also do surgical camps. And this is through public and private partnerships, like partnering with private hospitals, especially the faith-based hospitals. They seem to do really well with availing patient care that is safe in the surgical realm, and also the pharmaceutical companies to subsidize supplies, as well as the regional and global. Thank you so much for your time. I request that I stop here.